So let's talk about immunosuppressant drugs, and let's do it under 5 minutes. Okay. Yeah, now it works. So we have monoclonal antibodies. These monoclonal means clonal. Here we are thinking about this is one clone. Monoclonal means it just goes and it binds to just one head of the antibody. Okay, it cannot bind to a polyclonal. For example, IgM is a polyclonal because it has multiple heads, right? So that's the concept here. So monoclonal binds with IgG usually, or just binds to one head. Okay, it can attack only one head at a time. Okay, maybe I'm wrong of this IgG, so don't focus on that. So monoclonal antibodies, it means we have alemtuzumab. Alemtuzumab is a monoclonal antibody against CD52. It goes against B cells and T cells, and under T cells we have multiple sclerosis, under B cell we have CLL. Then we have bevacizumab. Now it's a monoclonal antibody against VEGF. Now what is VEGF? VEGF is vascular endothelial growth factor. Now we can give these antibody against colorectal cancer or neovascular macular wet degeneration in the eye. Then we have rituximab and natalizumab. Now rituximab and natalizumab have one very big side effect, that is they get high risk of JC virus, that is piloma, right? And we can get progressive multifocal leukoencephalopathy, PML, right? Now they work differently. Rituximab works by inhibiting CD20 markers, CD20 proteins on B cells, and natalizumab inhibit alpha-4 integrin. Now alpha-4 integrin is used for immune cells to migrate. Okay, so no addition, no transmission of these immune cells in the CNS. If we don't have these, we will have high risk of PML, of course. And natalizumab we can give in multiple sclerosis, and rituximab we can give in a broad spectrum way. We can give it in Hodgkin, non-Hodgkin, rheumatoid, autoimmune. Okay, so we can give in them. Both of them, rituximab and natali, have high risk of JC piloma, progressive multiple leukoencephalopathy, PML, and it's a demyelinating disease, so just know that. Then we have trastuzumab we can give in HER2 positive breast cancers, and note that HER2 new positive breast, these receptors are also present at myocytes. So if these receptors are attacked, we'll have cardiotoxicity and look for the ejection fraction going down. Okay, let's talk about anti-TNF mono antibodies. Right now, these anti-TNF mono antibodies, they attack the soluble TNF, okay, not the receptor. If we want to attack the receptor, we will gonna give etanercept. That's one of the very sept. Okay, just know that it's not an antibody, it's a recombinant TNF receptor. We can give it in IBD, we can give it in rheumatoid arthritis, and we can give it. And one of the side effects is TB reactivation, because once you stop the monocytes, macrophages, you'll have less granuloma. If we have less granuloma, then we're gonna have a lot of TB reactivation. And a patient who's working in some sort of dangerous situation, we can have silicosis in that patient. Then these silicosis actually stop the macrophages from moving, and then again we can have lower risk of granulomas. So a patient who has silicosis, we do not give anti-TNF antibodies, or we don't give Intercept. Okay, so that's one concept. Then we have ixekizumab and secukinumab, right? Now these both of them, they work against IL-17A, the activated 17A, not the Th17A. If we want to attack the Th17A, we're gonna give ustekinumab. Okay, so ustekinumab gives stops IL-17A, stop the keratinocyte proliferation, stop psoriasis. Okay, right? And note that cirrhosis is a disease of IL-17 and IL-23. Now we can stop IL-17 and IL-23 by giving ustekinumab, because these monoclonal antibodies, right, they stop IL-12 and IL-23, which in turn stop Th17. So when we are stopping Th17, we want to give ustekinu. When we want to stop 17A, we want to give these two drugs, weird name, ixekizumab and secukinumab, right? So that's one thing. Okay, so other thing we can give is eculizumab. Now eculizumab is again monoclonal antibody against complement which protein? C5. Now C5 and C9 makes MAC. If we stop C5, we're gonna have no MAC, and then we can target PNH. That's the night hemolysis, if you know, due to acidification of the blood due to when you sleep. I don't want to go into that. Other thing is that when we give eculizumab, we can have Neisseria because MAC actually is responsible for Neisseria, these encapsulated organisms. So we have to give meningococcal vaccines to these patients. Okay, so that was simple. Let's talk about other drugs. So other drugs is abexizumab. Abexizumab is a monoclonal antibody against GP2B and GP3A. Now these are for adherence, okay, the collection of these platelets via fibrins, okay. So fibrinogen, right, cast bridge on platelets so that they can cross link, right. And so we have adhesion and aggregation, right. And then we can stop the GP2B and GP3A, and we do this in PCI, in stenting, in angiography, right, angioplasty, and these are antibody abeximab. Other thing is that iptifibatide and tirofiban. These are not antibodies. They also act as analog receptors, right. They also stop and bind to these, but these are not antibodies, okay. So iptifibatide and tirofiban, these are not antibodies. Note this thing down, right. So we can have a lower risk of clots formation during stunting. Baslizumab and daclizumab, both of them are monoclonal antibody against IL-2. So we know IL-2 is for T cell activation, so we can give them in transplant patients. Denosumab actually inhibits RANKL activation. So if we stop the RANKL, we're gonna stop osteoclast, and then we have osteoporosis. We can give this in osteoporosis because osteoporosis is mainly handled by osteoclast. This biphosphonate actually works by permanently, irreversibly inhibiting osteoclast. Denosumab works by inhibiting RANKL. Omalizumab works by inhibiting IgE. And which part of IgE? Fc portion of the IgE, right. And we can give this in eosinophilic conditions, asthma, other eosinophilic condition as well, and we give it in last option, okay, as a last option resort. We don't give it earlier. These are monoclonal antibodies. This is monoclonal, this is not antibody. This monoclonal as well, okay. So other is Pallavi, whatever you want to call it. Palivizumab is a monoclonal antibody against RSV F protein. F protein means fusion protein. What it does is that the infected cells actually fuse together using F protein, and when they fuse together, they make something called as syncytia, whatever you can call it. And this syncytia actually is a multinucleated giant cell. So when we give Pallavi, we can actually prophylaxis, we can actually prevent the forming of these syncytia in RSV virus, right. Note that estrogen actually is inhibitory of class cells. So when we have old women, we don't have much estrogen, and then we have high osteoclast and we have osteoporosis, right. RSV, the treatment is supportive care. First of all, note that we don't want to treat because it's a cell resolving, okay. So that's monoclonal antibodies. So other thing is this is not monoclonal, this is just not antibodies, drugs. So let's learn about T cell first. T cell pathway, normal T cell pathway. So we have T cell receptor activation, then we have intracalcium channels open up and levels go up, then these activate calcineurin, and then NFAT is activated and it goes to the nucleus. Then NFAT goes to the nucleus of the cell, and then we have interleukin 2 transcription, and then we have interleukin 2 secreted, and then we have T cell activation, right. So that's how it works. So if you want to stop the T cell, we can stop at multiple point. We can stop using cyclosporin binds with cyclophilin then stops cycloneurin, right. So side effects of cyclosporin is that we have first gingival hyperplasia in the gums, right. Then we have nephrotoxicity because this afferent, the coming one, okay, the afferent renal constriction happened because of cyclineurin. So whenever we stop cyclineurin, we have these nephrotoxicity, note that, okay. And if you're stopping cyclineurin, we're gonna have nephrotoxicity, and if the nephrotoxicity is happening, we will have hyperkalemia because this potassium is gonna is gonna accumulate. If we have vasoconstriction, RAS gonna go up, and then we're gonna have higher hypertension because sympathetic activation, blah blah blah. We all know that. Gingival hyperplasia we're gonna have because cyclosporin actually acts via fibroblast, and then once the fibroblasts are activated, we'll have hyperplasia of the gums. Now, 3 drugs actually does that: phenytoin, verapamil, and cyclosporin. Note that it's a high yield. Information. Cyclosporin actually increase the hair. Once it increases the hair, we have hirsutism and hypertrichosis. Okay, so this was cyclosporin, right? Tacrolimus and sirolimus works differently. They sound same, but they works differently. Tacrolimus works by binding with a protein called FKBP. Actually, the name is FK506 protein, binds with it and it stops cyclineurin. Again, tacrolimus also gonna have nephrotoxicity, again hyperkalemia, again hypertension, but it is going to actually inhibit pancreatic beta cells, and then we're gonna have post-transplant diabetes in the patient as well. So again, tacrolimus goes and inhibit FKBP, calcineurin goes down, interleukin transcription goes down. Eventually, we'll have nephrotoxicity and diabetes in tacrolimus. In cyclosporin, we're gonna have nephrotoxicity and gingival hyperplasia and hirsutism. Okay. In sirolimus, what it does actually is that it doesn't actually stop calcineurin. It stopped what is called mTOR. Now, mTOR is a pathway. What is mTOR? mTOR is major cellular growth protein pathway. What it does is it actually signals the proliferation and the growth. So once you stop this, it actually is stopping the signals that are coming to the T cells, right? So IL-2 can be secreted, but the signals will not go and reach T cells, and they will not get activated. Okay. Now, it's not stopping the transcription. Sirolimus is sirolimus doesn't mess with IL-2 transcription. It messes with the mTOR. It stops the signals from IL-2 to the T cell activation. Okay, so that's how sirolimus works. So again, sirolimus works by binding FKB protein, same protein as here tacrolimus. That's why there are limus, right? So binds with FKB protein, stops mTOR, and then we have less signals to T cells, so less T cell activation. One of the major side effects is hyperlipidemia, because mTOR actually is present in the liver, and if we mess with the signaling pathway, we're gonna have abnormal lipid synthesis, so hyperlipidemia. These are non-antibody immunosuppressants, right? Cool thing. mTOR messes with lipids and lipid response, right? Calcineurin messes with nephrotoxicity and less transcription. And we'll have gingival hyperplasia and post-transplant diabetes in tacrolimus. That's it. That's the whole immunodrugs.